So thanks very much for the introduction. I think you're going to find that a lot of what I'm saying actually has been said already, because we're all on the same page. But I'm going to talk a little bit about debriefing, and I don't think that I will be able to turn you all into debriefers or even begin to go anywhere near that, because it's a process that takes time and practice and observation. But I thought, rather than try and do that, I would just give you some background as to why we debrief and some things to think about. And there are opportunities to practice debriefing out of simulation. You can do it at home. You can do it with more junior colleagues. You can do it with people. It's just, it's a communication skill. So I'm going to give you some top tips on that. So the debrief is the fifth phase of a simulation, and the other ones have really been covered already by the other speakers, but it is the one that leads to the translation to clinical practice and to change. And so it is a very important one, and important to get it right. So it's a structured process that occurs after a simulation session or training exercise. And the process aims to identify and resolve gaps in knowledge, skills, attitudes, and communication related to the individual, team, and/or system. So that's important. You know, it depends what you're doing. If you're teaching a skill, a procedural skill, it's very much individual. If you're moving into behaviors and attitudes and protocols, it's the team. And then if you're looking at the bigger picture, you might be looking at the system and how it works to support learners. And it also provides an opportunity for learners to reflect on their performance, discuss the decisions made, and explore the underlying reasons behind those choices. And I think that's something, that's one of the first things that you have to get used to with debriefing, is to relax your brain so that you give everybody a fair chance. And when you see things that they do, be they good or bad, or not so good, that you try and get under the hood of that and as to why that happened. And these are some of the kind of broad reasons why things go well or not so well in sim. I put knowledge base down the bottom because that's not the usual cause, and that's the one that we're most comfortable with, and indeed the hospital is most comfortable with. If something goes wrong, we are always saying more training. And if we see something in the sim that doesn't go to plan, we go revert to teaching mode, where we start teaching the 5 causes of sepsis or the causes of delirium. But actually, that's not usually the reason why people do things. These other things, assumptions, so people assuming that something has been done by somebody else, so they didn't give the drug because they thought the nurse had given it. Feelings, if people are very stressed, and it's a stressful situation, and you will know this from going to emergencies, you perform differently, usually worse. Goals, so if people are going into a sim and they know the goal is to thrombolize, they will have that, they will start to tunnel. And if anything else comes up in the sim, or it's any way outside of that tunnel, they will often underperform because they're just trying to achieve the goal. Rules, so this is the way we do this in this hospital. You're not allowed to call the reg X after 5 p.m. All of these kind of things kick in when people are performing. The same as in real life, these things are why people perform the way they do. Situational awareness, so just not being aware that something has happened or not happened. The influence of context, past experience. So in my last hospital, we used to do it this way. Code red in one hospital means something different in another hospital. And then knowledge base, people may have a knowledge gap. And if that's the case, then you address that with teaching. But I think you can see that if the others are the reasons, then teaching is not the solution to that in the debrief. So this is my favorite slide. The debriefing process is not an additional lecture opportunity. So if you want to do a lecture, use PowerPoint and don't use sim. I think you got a real sense today that it's labor intensive. There's a lot of moving parts and there's an awful lot of work. So use it wisely. So the debriefing is a process. It has quite a few parts to it, and some of them you use more than others, depending on what you're trying to achieve. And the ultimate goal is to promote reflective thinking and clinical reasoning. So just to keep that in mind. So it should assist in the development of insights, improve future performance, and promote the transfer and integration of learning to practice. And that's the job of the facilitator. I think it's a big job, and not all sims need to really focus on this integration of learning for practice. But if you keep in the back of your head that you are actually trying to change practice when you're running a sim, it moves you out of that teacher mentality. I think this is the paper and the work that was done in Boston by Jenny Rudolph in 2007 that started to change how we think about the debrief. We started to move away from the sort of finger pointing debrief, the identification of a person as not knowing something and that's why things went wrong, not really amplifying good practice. And so she brought out this paper, which is called Debriefing with Good Judgment. And the words are carefully chosen. It's not debriefing that is judgmental, and it's also not debriefing that is non-judgmental, because if you see something that isn't going to plan, you have to address it. You just have to address it in a certain way so that you're not finger pointing. Finger pointing in simulation is destructive for the learner. Issues can be addressed without singling out people because, as I said, it's very rarely an individual issue. There's lots of things going on in the background, so just be careful. People, I think quite a few people, although it's getting better, have stories of being tortured in a simulation, having a very bad experience, feeling very exposed, and then never come back to sim. So you do need to be careful what you're doing. So developing clinical reasoning and reflective thinking is promoted by the appropriate way we use debriefing. So there's three sort of types of this, and feedback is unidirectional. And I think we're all pretty good at feedback. It's coming from one person and there's no, you're giving advice. And that is very useful if you're teaching a skill, and it can be very useful for very junior learners. So really you are teaching in the sim, but it is for a very specific group, skills and junior learners. Debriefing is a technique that's bidirectional. So you are throwing something out there. It's like throwing a ball. You want them to throw the ball back to you. And in order to do this, we adopt a very structured approach where we have a reactions phase, an analysis phase, which is the most difficult, and a summary phase. A guided reflection is the next level up, where you as a facilitator encourage the learners to explore the critical elements of the experience in an effort to gain understanding and insight. So yes, you might have gone through your learning objectives and what you saw, and now you start to push them a bit more with very open-ended questions. How does this relate to clinical practice? Tell me about that in clinical practice. Tell me more, very open-ended. And that is a kind of a higher order skill. I think if you have a structured debrief and can get through that, it's a good place to start. And there's loads of debriefing models. I don't know, I'm not wild about any of this. I think it's complicating something that really isn't that complicated. But lots of people have done research on these. They're all pretty much the same. You have those three phases, which is the reactions phase, followed by the analyze phase, and followed by the summarize phase. The plus delta is one of the ones that came out first, and poor old plus delta has been given some very bad press recently. But I'm going to suggest it as the tool to use, because used wisely, it's simple, and there's some tweaks you can make to it to make it more effective. So the structure is a reactions phase. So when your learners come back, you'll ask them, how did it go? I like to ask that question specifically and give them some time. I'm just looking for their initial response. I don't want them to dissect the whole scenario. I want them to just answer the question, how did it go? Or how do you feel? Or how did you think that go? And the reason you do it is to sense check that learner to see, are they upset? Are they delighted with themselves? Are they hiding behind a cushion? Whatever. It's just so that as you move through the debrief, you're aware of where people are in terms of their performance. Okay, so that means you don't get caught out. Orientation to the events or recall events, you can do that either way. Orientation is just saying, so that scenario was about, you know, a stroke that needed thrombolysis or needed transfer or whatever, just one or two lines. That's important for more junior learners who may have thought it was something else. So it's just to clear the air. And then you can use a sort of a step through the events process if you want to kick off the debrief. It's not necessary to get to the analysis phase, but you can use it. This sense checking is really important to get everybody to settle down. The analysis phase I've highlighted there because this is the most difficult part, and this is the digging piece. So it's questioning people, it's throwing up things that happened, it's looking at the learning objectives and where they were achieved and discussing how they were achieved or how they weren't achieved. Open communication, it's conversational. And the big one to use is silence. So ask a question and everybody will shuffle for a little bit and you don't speak until they speak. And it can be very uncomfortable, but they get used to it. And somebody, I guarantee you, will always speak. So the facilitator should be saying less than the room. The summary phase is easy. We're just summarizing what did we learn. And rather than just keeping it to what did we learn in the simulation, it should be what did you learn that you can take out into clinical practice and apply. And then to check yourself, have you covered your learning objectives? In very complex sims where you have high-performing teams, the learning objectives can get lost because we get dug into specific issues around hierarchy and sometimes bullying, or things come up. So I like to write them on a flip chart and just at the very end, just check if I achieved them. So I like the plus delta. As I said, it gets a bit of heat because it's old, but I'm old and I still think I'm okay. So I like the plus delta. It's simple. And this is the technique that you use in that analysis phase. And it asks the learners really to assess their own or the team's performance against some standard. So what you do is when you get to the analysis phase, you ask two questions. What went well? And what would you do differently, or what can be improved, or some variation of that. And that's how you kick off the analysis phase. And from that, you springboard into digging down into each of the things that they highlight. And you sort of end up with two lists, the plus list, which is the things that went well, and the delta, and the negative list, which is the things that can be improved. You can, if you use the plus delta wisely and flexibly, it can perform better than you might think. It gets a bit of heat because it's very rigorous and it's very regimental. But as a novice debriefer, I think it's a real safety blanket because at least you know where you're going and you know the steps to take. But you can flip it. You can decide, like in anesthetics, if we're running a simulation that's around the loss of an airway, and we notice something particularly around the actual intubation piece, you can just, with the plus delta say, okay, I'm not going to look at the whole picture of managing an airway. I'm actually going to specifically look at intubating when the airway is obstructed. So you can pick out and you can focus a very specific piece, and then you go back to what went well and what went not so well. Really a good way to stop people focusing on all the negativity, because I think we're really good at that. You ask people what went well and what went not so well, and they'll start off with all the things that they thought didn't go well. So we call this use a single barrel versus a double barrel debrief. And so you just start with what went well, and you don't give them the next piece, which is what went not so well, until they've covered all the good things. So single barrel debriefing is good. And unpacking positive performance is really important. If you think of SIM as being a very powerful tool, and whatever happens in SIM translates out into clinical practice, then amplifying what you saw that was really good and spending time asking people, how did you do that so fast? How did you engage the team? How did you know to do it? Tell me how you made a decision, so that we can learn from the good and not focus on the not so good. So, anybody in SIM really should get themselves a t-shirt that says it depends, because it depends is the answer to nearly everything in SIM. It's complex and it's broad, and we use it in many settings, and the setting you use it in depends on what you do. So the debriefing process should be selected depending on the complexity of the scenario, the learners, time available, skill of the facilitator, and the learning objectives. If you're teaching lumbar puncture, you will be using feedback, structured feedback. So that's clear. If you're teaching undergraduate students the causes of stroke, you will again use a very simple sort of unidirectional type of feedback and not really veer outside that. As the medical students become more senior, you might start to do this kind of back and forth. And then as you move up into more skilled learners and certainly high performing teams, you need to change how you debrief. And if you are using SIM for safety and quality improvement within the hospital system, then you absolutely need to be able to move into a space where you're getting bidirectional feedback all of the time and very open-ended questions. So this always causes a problem, learning objectives and outcomes. I think John has mentioned some of this. A learning objective should be clear, measurable, and relevant. The learning outcomes are the bigger picture. So it's what you're trying to get to at the end of your training or at the end of the simulation series or whatever. But they are not something that you're assessing as during a sim or looking at or observing. It's the learning objectives, and they should be very specific and well written. A useful way to kind of decide, well, you know, do I need to do this in a big lab? Do I need to have an expert psychologist debriefer? What equipment, what resources? Is this Roosen and Weinstock piece of work, which is about sim zones and sim zone levels, which came out in 2017. And I like it. It gives you some sense as to what you're heading into before you head into it. So it aims to match the simulation development, delivery, and debriefing process to the specific needs of your audience. So who are your learners and what are you trying to do? And once you have that written down and your learning outcomes, then you can decide what resources do I need, where do I need to do it, what kind of debriefing do I need to do, and am I able to do that? And if not, get somebody else in or do a different sim. So broadly, there's simulation that's used for skills, education, and training, where the goal is to achieve the skill. And remember, skills are not just technical skills, they are team working skills, non-technical skills, leadership skills, communication, protocols, all of those things are skills. Translational simulation, the goal is to improve the quality or safety of something specific. And actually, a lot of simulation in geriatrics falls into this translational simulation if you want it to. If you think of the processes that you have to implement and navigate, there's a lot of time-dependent procedures. There's a lot of transitions in care, and there's a lot of things that really depend on the system working to support you. So decide where you are with this. So these are very basic skills, and I think you can see that this is, you know, unidirectional facilitator teaching procedural skills to MCHDs. These are more complex skills. These are ultrasound guided vascular access, again, unidirectional feedback from a senior clinician to teach that procedural skill. This is also unidirectional feedback, but we're moving into the mannequin space. You know, this is a second-year medical student, and he's been taught to examine the chest as a clinical skill. The next level up is where we're starting to move into a clinical context. So we might have interns working with nurses, so we can move now into a debriefing. And again, the plus delta is very useful in that space. This is a sim that's an IGPOP sim, that's a quality improvement sim or a systems probing sim, where what we're looking at is the interface between the frailty service and the community care group. And if that's what your goal is as a quality goal, then there's no point in debriefing to the causes of frailty. That's not what this is about. The debrief is a much broader systems-based debrief. And this again is another complex sim that's for patient safety. So this is a PPH, postpartum hemorrhage, with the full team in. And again, we're not teaching the causes of PPH. We're looking at how that works, how that runs, because you'll notice that it's at 4 o'clock in the morning. And obviously that's very challenging for people. So the focus of that debrief is very different. These are the sim zone levels, and I'll send John and Emily the paper so that you can have a look at it, because it is useful. It goes from 0 to 4. 0 is sort of automated feedback that comes from AI or from a simulator that has haptic feedback on it. But the ones we're interested in are sim zone level 1, 2, and 3. And sim zone level 1 is that teaching a specific skill, follow a protocol. It's very much instructor led, and we call that a how-to simulation. So we use that in undergraduates and for interns. Sim zone level 2 are for non-native teams. So that's where you're bringing learners together from different groups. They're not actually a team. They work with each other on occasion, or maybe they don't. So ward nurses and SHOs and lab staff. And this is contextualized clinical skill building. So you're recreating the context. We are still looking at skills. And the best debrief method to use there is the plus delta. And then sim level 3, where you've got native teams. And so they're teams that are working together. They're usually surgical teams, emergency medicine teams, neonatal teams. And you're facilitating the team. And we're all the time looking at behaviors, quality, and safety goals. So they're all a bit different. I think this is important. The acquisition and progression in the expertise of debriefing skills is a continuous process that demands constant attention, practice, and development. But it all doesn't have to be done in the sim lab. It's just about learning to communicate. And for your debriefs and your communication to be effective, you have to be able to create psychological safety. And I think that's been alluded to several times. It starts at the very beginning of the sim work. This is what psychological safety is. It's a shared belief held by members of a team that the team is safe for interpersonal risk-taking. So people might think that psychological safety is about the environment, but it isn't. It's about creating a situation so that people will speak to each other frankly and kindly at the same time. So it's about the organization and the culture more so than anything else. And psychological safety is not all about speaking up, which is challenger safety. I mean, there's lots of other important pieces. Inclusion safety. So that's that people feel part of a team, and that's really down to respect. Learner safety, that people can make a mistake or can say they don't know or can ask a question. Contributor safety, people can say, I have an idea. Why don't we do it this way? And challenger safety is where they're challenging something. And that's a very higher order challenge to deliver in simulation. But if you can do it, if you can create these things in a simulator on a regular basis, then that will all translate out into practice. The same way as if you learn how to do a lumbar puncture in the simulator, you will be better in practice. If you learn how to do this in the simulator and it's done properly, you will be better in practice. So now you see how sim is starting to change culture as opposed to just training. It's really moving out of the box of being a training tool. And psychological safety, people will often say, well, I don't understand how sim for teams actually improves patient safety. And this is how it does it. So you have to achieve psychological safety. And psychological safety in the clinical space is linked to real world team performance through the impact it has on interprofessional risk-taking, speaking up behaviors, teamwork behaviors, and team learning. So you're teaching people how to do these things in the simulator. Sim works because it is a leaky environment. So at the top of the bucket, if you think of sim as the bucket, at the top of the bucket, the water comes in. That's the people coming in with all of their baggage. They may have had a bad day. The ED may be full. There may be no beds. Beaumont may not take people, etc. I may not like you. You may not like me. We may have had a fight. That all comes into the bucket. We run the sim and things leak out back out into the clinical environment from the sim. And so what you want to leak out is amplified good practice. If something happens in the sim that's not super, it needs to be managed in the sim so that it's dealt with, and poor performance doesn't leak out into clinical practice. And I show these slides to sort of highlight it. You know, this is a big team coming into sim. They all look happy, but this is 8 a.m. It's that shift changeover. I don't know what has happened in that shift. I don't know how many beds are in ED. I'm pretty sure that they're all smiling, but I'm pretty sure that there are interpersonal problems and issues and staffing shortages. So they're bringing that into the sim. And I have to be able to manage it as a debriefer. They then run through the sim and we're observing their performance. And then you bring the two of those things together, which is what's come in plus what you saw, and you handle it in the debrief so that you can address those issues. And when they go back out onto the floor or in the next day, that nobody has been compromised. You know, if that reg performed a little, wasn't good at intubation, does the nurse that was assisting have a different view of them after the simulation? And when they go back out onto the floor the next day, are they thinking, well, I always knew he was a bit rubbish, and now it's verified? So you want to be able to handle good performance and bad performance or poor performance. So my top tips to finish up: start small, start with very basic sims and practice your communication skills and your feedback. Watch a really good debriefer, see as many of them as you can. That's the best way to learn. Always be respectful, so pull in your horns. People do things for a reason, so we always come from a stance of respect and curiosity. So we want to know why people do things as opposed to finger pointing, and we want to dig down as to why they do them. People make choices for lots of reasons, and we've covered the reasons here, and the knowledge one is way at the bottom. Maria spoke about this. This is the basic assumption, which is usually on the wall of every simulation facility. We believe that everybody participating is intelligent, capable, cares about doing their best and wants to improve. And we reiterate that at the pre-brief and the debrief. Templates are very good when you're starting out. So use a template to design your scenario. John mentioned that. Use a pre-brief cheat sheet because there's quite a lot to remember. We have some that you can have. And there's no problem standing up and reading out of it. People don't think any less of you if you read it. You don't have to remember it all. It's just to make sure you hit all the points. We have a cheat sheet for identifying your sim zone as well. So identify that and choose what debriefing style you're going to use and make sure it's within your capabilities. Practice conversational techniques on anybody who you want to torture by asking open-ended questions. I torture my family with these all of the time. It's a good way to hear yourself speaking. And these are the kind of questions, you know, tell me more about it. Can you explain that more? What are your thoughts on that? Rather than just jumping in with your own thoughts and your own clinical knowledge, just to say, you know, what were you trying to accomplish at the time? What were you thinking? What did you notice? Keep going. Tell me more. Tell me more. If the facilitator at the top of the room is doing all of the talking, they're teaching or giving feedback. So they're not debriefing. So just watch that. This is really useful. This is what I put in my head when I'm debriefing. I imagine that I have a ball and that I'm doing these patterns. So the audience is in front of me. I'm throwing the ball out to individuals. So that's the sort of fan one on the left. That's a good place to start, to make sure that you hit various people and you're not just focused on the same poor crater. That's a kind of a basic debriefing. You then can move on to this triangle piece where you're throwing out the question or the ball in your head, and you're hoping that the person you throw it to will then turn to another person for verification or to come on in. And so you're focusing maybe on the people who were in the simulation and a little bit less, but still including the audience. And then the holy grail is this net, the one on the right, which is where you throw out the question and the question really is bounced around the whole audience by the person you threw it to asking something else, somebody else chiming in. And so you brought in the whole room. So people will often criticize Sim and say, well, only 3 people got to participate. But that's irrelevant. It's everybody can get to participate if you can do the debrief the correct way, and people bring interesting things to the conversation. There is a standard for debriefing, and it's part of the Society for Simulation in Healthcare standards. And that's kind of all I have to say. So I hope that was helpful. And thanks, John, for the invitation.